Hey there. How you doing? Good evening and welcome. Howdy America. I'm Dr. Randy Fink and this is Fertility with Fink, the place where you are supposed to be every Tuesday evening at 5 o'clock Central, 6 o'clock on the East Coast. It's 4 o'clock in the mountains and 3 on the West. I am a fertility gynecologist at New Life Fertility in Pensacola, Florida. And as always, it is a real pleasure to be with you on this Tuesday evening where we can talk about all those things that are important to us, all those things that are about making a family, about fertility, and about doing what it takes to find that ultimate goal of happiness in a family. Um, we are here as always with a bunch of different feeds. We've got, let's see, we've got YouTube and LinkedIn and Facebook down here. We've got a couple of different Instagram feeds. We've got mine at Randy Fink MD, and we have New Life Fertilities right over here as well. Great to see everybody. Hello, SB Charles. Hello, Angela. Hello, Shaylin Liss. Nice to see you, Rosa. Thank you for being here very much. Sharmella, as always, thank you for joining us in your pregnant state. Hi to Kaylee. Kaylee Gordon, as you may know, is one of our wonderful nurse practitioners at New Life Fertility in Pensacola, Florida, and is a great resource for you as it pertains to your fertility care. Well, let's see what's going on, folks. I happen to be in Colorado this week, and I came here for my son's graduation from college, which, gosh, happened so very, very quickly. We've got some issues here. Looks like with our there we go. I think we're okay. Having a little popping in and out, it looks like on one of the Instagram feeds. So I came to Colorado for a high school graduation, and it's just amazing when you look and see how quickly the time really truly goes by. And I'm sure we all have our own experiences about what that means. Jasmine is with us, who is one of our wonderful embryology team at New Life Fertility in Pensacola. How are you folks doing? How's your week been? How's your weekend? It's let's see, what do we have here? It's about 65 degrees in Colorado. I think back home in Pensacola, it must be in the upper 80s today, but it's kind of been a little chilly over here, and summertime is just around the corner, and those are the days that we all just wait for. Summer, even back to childhood. I don't know if you feel the same way. Summer was always so kind of really very magical. It had to do with summer vacations and just not being in school, being able to sleep late, and oh yeah, those were the days, weren't they? Oh gosh. Shaylin Lease, it looks like, says, I got pregnant last year with twins. I saw you in Colorado and my eggs had released, and you only got four of my eggs. I couldn't do a fresh transfer, but I got pregnant within weeks of the meds. Oh my goodness. So I guess you're saying that you did an egg retrieval and then you spontaneously got pregnant after that. Well, I think that's fantastic. And you had the spontaneously pregnant with twins, which is unbelievable and fantastic. I wish I could tell you how many times I have heard a very similar story to that. And sometimes it's really just a question of going and having a consultation with the fertility doctor. Oftentimes that's enough to make people kind of end up getting pregnant, which I think is really fabulous. It's a kind of a therapeutic consultation when you visit with the doctor. Just have a talk about things, and the next thing you know, you got pregnant. Well, it sounds like you went through an egg retrieval, so you had a rough time of things there, and you got four eggs, but spontaneously pregnant after that. Man, I love to hear those stories. Sharmilla says, I am 31 weeks pregnant today. I had the Tdap vaccine. Is there any other vaccines I need to take before delivery? Well, Tdap is really probably the most important one in the general population because it covers whooping cough. And of course, our babies are not immune to whooping cough. And if they contract that disease, it can be devastating to them. We have all been vaccinated for whooping cough. And I think you get that first vaccine. Well, it's certainly sometime in childhood. But for whatever reason, our immunity to the whooping cough part seems to wane. It seems to drop off. And so that's why it's important that we be vaccinated. And everybody who's going to be around the baby really should be vaccinated for the whooping cough, before the baby comes in the house. And that way, the baby will be protected. That's really the most important one. Now, moms who are Rh negative, their blood type is negative, those folks do a vaccine that's called RhoGAM, or Rh immune globulin. And what that does is that if you're Rh negative, let's say your blood type is O negative or A negative, and you have conceived with someone who's Rh positive, which is the greater likelihood, you can, due to the fact that the baby is inside of you, when the baby's cells are exposed to yours, you can develop an antibody against those blood cells. And so women who are Rh negative end up getting the vaccine because it will prevent you from developing an antibody to an Rh positive type blood cell. So that's called Rh isoimmunization of pregnancy and is protected simply by RhoGAM. Now, it's an extremely safe vaccine. It's been around for decades and decades and decades. There really is no controversy with it. So I'd feel that's a pretty important thing to do. Usually you get one of those vaccines if you're Rh negative when you're about 28 weeks. And then depending on the baby's blood type after the baby's born, you may get one in the immediate postpartum period. So Sharmila, the Tdap, or the tetanus diphtheria pertussis vaccine, is really the only one that's routinely recommended during pregnancy. Now, a flu shot is also recommended during pregnancy, and there has been some controversy over COVID. I understand that the recommendation just came out saying that the COVID vaccine is no longer recommended for healthy people and pregnant women. And so we'll see how that ends up playing out. But as far as the other vaccine, yeah, I think that's what you want there. Hey to Alexis over on the Facebook side. I hope that a consultation will be all it takes to get me pregnant. I hope so too. I think that would really be fabulous, and happy to do you that service, Alexis, as anything that we can do. Fertility support by Suzanne. Great to see you here. And Olivia Williams, you as well. Shaylin says, well, you had twins, but you had them early at 27 weeks. So that's one of the reasons that we often say we in the fertility world are quoted as saying, we want you to have one healthy baby at a time. There are a set of guidelines which we follow that have to do with the number of embryos that we might put back inside of you or transfer back to you if you've done IVF. And the goal is always to get you one healthy pregnancy. Some people say, well, I don't mind having twins. And indeed, the idea of having multiple gestation is it's charming. You can dress them up and they wear the same clothes, and then they grow up together, and twins, everybody knows somebody with twins, and it's not, such a terrible thing. But the fact, Shaylin, that you had your twins at 27 weeks, that's a tough go of things. And I'll bet you could really tell everybody how hard that was on you and your family, having to go visit your babies, having to see them so small, having to wonder what was going to happen at every little step of the way. Would they leave the hospital completely normal? And it is my prayer for you that they have. But that's a rough road, and it's one that we certainly wouldn't wish on anybody. Twins do happen spontaneously. Triplets even happen spontaneously. In fact, there's reported cases of spontaneous quadruplets. Doesn't happen very often. And as far as fertility treatment goes, if we can prevent that from happening to you, then we feel like we are putting you in a much safer place, you as well as your children. Oh, let's see. Hey to Kowsar and Ashley. Hello. Rosa says, I had a subchorionic hematoma, moderate to large at 8 weeks pregnant. I'm now 17. It is still there. Is this an issue to be on aspirin, or should I not start aspirin? Well, so Rosa was on Lovenox earlier on and had a little collection of blood beneath the placenta. And this is what's called a subchorionic hematoma. It's not an uncommon finding. And in fact, we see it very frequently. One out of every two pregnancies, you may have heard me say, will have some cramping and bleeding in the first trimester. And that is, again, also not an unusual finding. And a subchorionic hematoma is one of the more common reasons that that happens. Um, what is it exactly? Well, as the uterus grows and the placenta is attached to it, the uterus grows, the placenta can shear off a little space underneath there, and that can result in a collection of blood. Like any other bruise in the body, most of these blood collections will disappear on their own. So I always say the same thing. If you punch me in the leg and I get a nice bruise from it, well, it's going to turn all kinds of colors. It's going to go, black and blue, and then it's going to kind of become pale and maybe a little yellowish green, and eventually it's going to go away because the body is breaking down that blood product that's collected there. In a subchorionic hematoma, the same thing happens. Most of that clot will be resorbed on its own, but sometimes it will want to escape out the door, as we say, because that's a little easier exit. And that's what can cause vaginal bleeding, particularly in the first trimester. So you are on Lovenox at the time, Rosa, and Lovenox, as we know, is a blood thinner. That can be something which can contribute to we got a little problem over here on the, let's see if we can fix this business here. I'm trying to fix, we got a little connection issue on one of the Instagram feeds. And while I am talking to you, I'm trying to troubleshoot that at the same time. Let's see, forgive my fingers in your face here. Oh, but we can do this. I know we have the technology. Bear with me for a moment here. There we go. Okay. Well, now hopefully that's going to fix that feed. If there is we're talking about subchorionic hematomas, and if there is a subchorionic bleed and you're on Lovenox, if you're on blood thinner, then usually I do recommend that you stop the blood thinner, because the blood thinner is not really going to help anything at that point in most cases. Now, many times we have people on these blood thinners, let's just say they are empirically on the blood thinner. That they're on it because, well, we think that it may help them, as opposed to the fact that we've done some test that shows they need to be on that blood thinner. And if you fall into the first category, where we have you on the blood thinner because it sounds like it's going to be a good idea, then I'd say absolutely I'd want you to stop it. Now, if we've tested you for something and we found that you need to be on that blood thinner, well, that's a different scenario. And then we may have to talk about it. But Rosa's asking about whether she should start up on baby aspirin. And I would say at this point, the answer is no. By the time you're 17 weeks, Rosa, in most cases, that little hematoma has resolved. It's probably gone away. In your case, it's still there. I don't see a compelling reason to be on a baby aspirin. Now, we use baby aspirin to help some people prevent clot formation. Although really the Lovenox, the blood thinner, is really the drug of choice for people who truly have an issue with what's known as a thrombophilia, or a condition where the blood wants to clot. However, baby aspirin is used in folks who have a history of a hypertensive disorder, a pressure problem in pregnancy, something like preeclampsia. Um, A baby aspirin has been shown to have some preventative effect on developing another hypertensive disorder in a subsequent pregnancy. So that's a good reason that we might say folks should be on it. Um, Short of that, Rosa, I can't think of a good reason that I would say you should start it up. So I think you are probably fine not being on it now. And I am pretty confident that you will ultimately see that little bruised area beneath the placenta resolve. Let's see. Well, cows are says I got an HCG LH supplement in my IVF meds instead of Menopur. Does it work the same way and have the same effect during stimulation as Menopur? Well, not exactly. The answer to that is not exactly. So, first of all, if you were given HCG LH, it would mean that your dose of FSH, that's either Follistim or Gonal-f, probably needs to be increased to compensate. So, what is Menopur? Menopur is a combination of the FSH or follicle stimulating hormone, like you have in um, Follistim and Gonal-f, but it also has some HCG derived LH. So if you're getting HCG LH, well, it's certainly a lot less expensive than Menopur, but it is not the same thing because it's missing that FSH component, and that means in the first drug that you have, either the Follistim or the Gonal-f, you need to make sure that you have more. So if I were to give you a drug regimen for IVF, let's say 150 units of Follistim and 75 units of Menopur. Well, that really totals 225. What I say, 150 and 75. I think that's what I said. 150 of FSH and 75 of Menopur. That really totals 225 units of FSH plus some of the LH. So if you got the same 150 units of Follistim, but they just plain old black and white substituted the Menopur, then you're not getting enough FSH. Depending on where you are, there are some practices that will routinely that maybe won't even use Menopur. They will routinely just pick HCG because it is less expensive, but the outcomes may not be as good. Menopur is associated with a little better egg quality, but at a pretty significant difference in price. So that little vial that you got of HCG LH probably cost about $150. Whereas any 1 day supply, 75 unit vial of Menopur is probably about $85. So, that's a pretty significant difference in cost. So, but the thing I'd want you to know is that they are not interchangeable, that there needs to be some variation in the FSH dose that you were to get along with your Menopur. Now, again, you may find that your practice has compensated for that when they changed it. Sometimes the pharmacy there was a time when the pharmacies were having a hard time getting Menopur. They had temporarily stopped production due to some manufacturing issues. And in that time, we used HCG-LH, but since then, that has all been rectified, and really it should be pretty easy to come by. So do check and make sure that there's a compensation for your dose there, okay? Because not the same thing. Annie Nicole is here. Hey, nice to see you this evening. Mostly Mo says I had my daughter at New Life Fertility. She just turned 10 years old. From Dr. Rips, who is my partner at New Life Fertility. And she says, this clinic is the best. God bless you. Thank you so much. And congratulations on a 10-year-old. Boy, that time goes by so fast, doesn't it? It's really amazing what happens there. And a special hi again there to Jasmine. Olivia Williams is also here. Thanks for being with us this evening. If you're just joining, it's Fertility with Fink live, as we are every Tuesday evening to talk about all those things that are important. Ask your questions questions here, throw them up. We've got Instagram, Randy Fink MD, and New Life Fertility. We've got LinkedIn and Facebook and YouTube all right here as well. If I can't get to your questions tonight, I am able to do so. If you would simply send an email to askfertilitywithfink at firstfertility.com. That's askfertilitywithfink at firstfertility.com. And if I can't get to the question here during the live, then you will be at the top of the show next week. Although I have to say, I apologize. I did not look at that email today before we went live. So if you ask me a question beforehand, then I will reply to you directly. T. Andres, hello. Nice to see you, the Styles family. Rosa says, I have a day 7 blast. It's a 4BB embryo. It could not be biopsied due to being so compact. Does this mean it is likely that the embryo is genetically abnormal? And I would say no, it doesn't mean that. I don't think it has any greater a likelihood, except what I can tell you is that a day 7 embryo doesn't function as well as a day 5 or a day 6. And so, what does a day 7 blastocyst really mean? It means that, well, normally we say under ideal circumstances, an embryo becomes a blastocyst at about day 5. And what does that mean? Well, before that, it's what's known as a cleavage stage embryo. And a cleavage stage embryo is an embryo that is just trying to figure out how it's supposed to divide, how it's supposed to become a little functioning factory. So it starts out as 2 cells, and then it divides and becomes 4. And then those 4 cells divide and it becomes 8, and so on. It's just still trying to figure out how to divide those cells. If you remember anything from high school biology, it has to do with mitosis. But by the time it reaches a blastocyst, typically on day 5, is a little functioning metabolic factory. It is no longer just trying to figure out how to grow, but rather is trying to figure out how to live. All those little biochemical functions that happen are happening with great skill and prowess as that embryo continues to move its way on. So most of the time, an embryo will become a blastocyst by day 5. In some cases, it takes a little longer. So maybe it takes till day 6 for that embryo to become a blast, or maybe it takes until day 7 for that embryo to become a blast. Well, if it took 5 days, that's pretty normal. If it took 6 days, for the most part, that's still pretty normal too. If it took 7 days, um, those embryos don't function as well as the day 5 and day 6 blasts. Does that mean that they are any less or more likely to be euploid? I don't think that we can say anything about the chance of it being chromosomally normal or not, because there are plenty of day 7 embryos that come back to be chromosomally normal. Yours was a 4BB embryo, so it's kind of what we would consider to be a fair quality embryo. But usually that means that it's just a mechanical issue, because when they're doing that biopsy, Rosa, what they're doing is they're taking some cells from the outside portion of the embryo, and that's the portion that's known as the trophectoderm. The trophectoderm is the portion of the embryo that will become the placenta. They take a little bit of that goes off to the lab. But if for some technical reason, like the embryo is too tightly compacted, they are not able to get those cells. When they do that biopsy, it's actually usually done using a very, very tiny laser. And so I suspect that means there was just, again, something technical about how that biopsy was done. So again, to answer your question, I don't think it necessarily pertains to the likelihood of it being chromosomally normal. But I can say that a day 7 embryo, we just don't expect that it will have as high a success rate as a day 5 or day 6. Not that it can't, because it certainly can, but strictly in terms of statistics. Let's see. Why do, and this goes back to Shaylin's question: why do women have babies early? I didn't make it past 28 weeks. Um, we were talking about she had a spontaneous pregnancy, it sounds like, after having an egg retrieval done. And like I said, that absolutely can happen. But then you got a cerclage. What is a cerclage? A cerclage, and that's spelled Cerclage. A cerclage is a procedure where we place a suture in the cervix to help hold the cervix closed. And this is for something that we call an incompetent cervix. So there's really two reasons that people can have a preterm delivery. The first is outright preterm labor. And preterm labor happens when the uterus starts contracting and the cervix starts to dilate as a result of those contractions. What is a contraction? What is the uterus? Its job, it's just a big piece of muscle, and its job is to squeeze a baby out when that time comes. But until then, it's supposed to sit, relatively quietly. Labor is defined as contractions that cause cervical change. Now, people can still have other reasons to deliver. People can get infections on the inside. People's placentas can start to separate. But in general, we think preterm labor is problem number one. The other type of problem is what's known as an incompetent cervix. And the cervix, if you remember, its job is to, if this is the uterus and here's the cervix, its job is to stay closed here, because when it opens up, that's how the baby comes out, right? So the cervix has to stay closed. And if for some reason the tissue of the cervix is not strong enough to stay closed, that's what's known as an incompetent cervix. In other words, the cervix is starting to dilate and open up in the absence of contractions. That's called an incompetent cervix. And for that, we place a stitch through the cervix to try to help hold it closed. Now, when that happens on an emergency type basis, that we kind of find out, oh my goodness, look here, the cervix is, 8, 9 centimeters dilated, or maybe even completely dilated at 18 weeks, then we say, whoa, that's what we call an emergency cerclage. And we put that stitch in just to try to hold that pregnancy in for as long as we can, because let's say it happens at 18 weeks. Well, something in pregnancy happening before about 24 weeks means there's an extraordinarily low probability that the babies will survive, because that's really the point that we call the viability, the point after which a baby theoretically can survive on the outside. It's usually about 24 weeks. So you had a cerclage, which means that there was some issue with your cervix in and of itself being able to hold itself closed. That's called an incompetent cervix. Why do other people go into preterm labor? Well, to be honest with you, that's one of the things that we just don't know. The only risk factor that we know of to try to prevent severe preterm birth is the interval between the time that you have a first baby and the next baby, or a second baby and the next baby. But between the time you have a baby and the time you have another baby, that's called an interpregnancy interval. A short interpregnancy interval is known to be the only risk factor, the only preventable risk factor for severe preterm delivery. So why did that happen? Gosh, it's really hard to say. It does mean that with subsequent pregnancies, you are at risk for it happening again. Folks with a history of preterm delivery, there have been some interventions over these years that the medical science has tried to try to help prevent preterm delivery. Ultimately, what we know of is that close monitoring is really the best thing that we can try to do for you. And if it looks like there is going to be, or that there is a risk of preterm delivery, we give you an injection of steroids, and that's called betamethasone, is the steroid injection. Why do we give you steroids? Well, because that helps to mature the baby's lungs. So the biggest issue that happens when a baby comes out, and there can be all kinds of problems that a preemie can have, but the most important one is that, well, it's got to be able to breathe. And if the lungs are not well enough developed, yet to be able to allow for respiration, to allow for air exchange. Um, that's a problem, and that's why we do the steroids to help accelerate that lung maturation. Remember, the baby on the inside is not breathing air, right? There's no air in there. The baby is getting oxygenated blood through the umbilical cord that's traveling from you, mom, from your basically your lungs, oxygenating your blood. That blood is traveling through the placenta, through the umbilical cord, and to the baby, where it's perfused around the baby's body. That's how the baby gets oxygen. So on the inside, the only way they breathe per se is to get the oxygen from you. But once they're on the outside, then it can become a challenge, because if they haven't yet learned how to breathe, or if the lungs have not developed the capacity to breathe the air on the outside yet, that's one good reason that a baby has a problem in the NICU. So, a hello to Brandis, if you are still here. Brandis Montez at CNY Fertility in Colorado is also a wonderful nurse practitioner, my former colleague. Shaylin says, in continuing that thought about the preemie, I want another baby, but I'm scared to have another preemie. And yeah, indeed, that is a risk factor, and something that certainly you'll want to talk about with your doctor before getting pregnant again. And when we talked about twins, twins or multiple gestation has a significantly higher risk of preterm delivery than does a singleton pregnancy. And that's why I was saying that in the fertility world, we really want you having one healthy baby at a time, because the risk of preterm delivery is so much lower with a single baby compared to having multiples. And so there may just have been an issue there, Shaylin, with multiples. Angela says, my midway labs today, the estrogen was only at 144. Is that too low? Have you seen success with low estrogen? The beta is on Friday. The answer to that is yes. So, in large part, I don't really consider that estrogen level to be all that important. And there are many factors that can make it seem low. For instance, if you did a modified natural or a natural type cycle, and you took some letrozole to help with ovulation induction, that will artificially lower your estradiol level. The most important thing about the estrogen level is that it thickens up your lining to the point where that lining can support a pregnancy. And most people use a number of about 7 millimeters at the time that you're either ovulating or that you start your progesterone. And as long as that's okay, I would not recommend that you randomly treat an estradiol level. There are many practices that do not even check it for that reason. Now, if it came back and it was, shockingly low, and 144 is not shockingly low, and I might say, well, gosh, I don't really know what that means, but hey, it's going to make me feel better to treat that number. But in your situation, I would not recommend that you do that. Mama of twins and a surprise. that is a great that is a great handle there. I do like it. And a hello to Zenny in Miami. Thank you as always for being here on this Tuesday evening. Let's see here. It looks like Riaz joined. Hello. Um, Somebody here said, looks like Angela said, I get better results with Gonal F than Follistim. And there are some people who do feel like they get better results with one versus the other. They're both really what are called recombinant FSH. That is to say that they are manufactured chemically in a laboratory, and they're really structurally speaking very similar. There may be some slight difference in the preservatives. I think there's a difference in the way they are supplied as far as uh, the device used for injecting and what you have to draw up, and one has a little pin that you can just dial the number in. But some people do feel like they get better results with one versus the other, and that's yeah, I think that's absolutely fine. Dancer is here with us and says, I am 5 weeks pregnant from an IUI. Congratulations. That's outstanding. And before we get to the rest of your question, let's just highlight for everybody what is an I. We talk an awful lot about IVF here, and IUI is also certainly a meaningful way to get pregnant. Why do we focus so much on IVF? Well, the answer to that is that if you look at the outcomes, at the probabilities that you're going to get pregnant from one intervention versus the other, IVF is said to be the fastest path to pregnancy, the most reliable path to pregnancy, and really the most efficient means of getting there. It's also the most invasive. It's the most expensive, and so it may not be the right choice for everybody. IUI is an option where we give you medication, typically to make sure that you're going to release an egg at a predictable time, and we have partner sperm. We prepare that sperm in the lab and separate out the best and the strongest swimmers and place them inside at just the right time so that we can maximize the opportunity for sperm to be able to meet egg. That's what an IUI is, an intrauterine insemination, or what we also sometimes call artificial insemination. Okay, so Dancer is 5 weeks pregnant from an IUI. I've been spotting since last Thursday. Beyond scared. I'm taking my progesterone twice a day. Don't know what's causing this. Well, there is nothing that scares a girl more than bleeding in the first trimester. Very much so. So, what are some causes of that first trimester bleeding? You might have heard me say a little bit ago that 50%, one out of every two pregnancies, has some cramping and bleeding in the first trimester. It is not an uncommon finding, and it is not a herald of terrible things that are happening. It does not mean that you're having a miscarriage or that there's something about the pregnancy that is not going to continue. The most important thing that we want there, Dancer, is that we want to be able to look and see a heartbeat. When we look with the ultrasound and see a heartbeat, which is usually comes just after about, between 6 and 7 weeks of pregnancy. Once we look and see that heartbeat, we know that 95% of those pregnancies will continue on without having a problem. So the best odds we can hope for are seeing that heartbeat just after 6 weeks. So what can be causing your bleeding? Well, we talked about a subchorionic hematoma. And what that means is just that the placenta shears off a little space as it's implanting in the uterine wall and as the uterus is starting to grow. You collect a little blood, that blood's flowing, again, all that blood's flowing from you through the placenta, through the umbilical cord to your embryo at that point. A lot of blood going there, so it's not uncommon that a little bit wants to leak its way out. People can have something that's called an implantation bleed. And an implantation bleed typically, technically implantation occurs probably in the week before you get your period, but sometimes just as that pregnancy is trying to grab a hold and take root in the couple of weeks after that, it may leave behind a little blood. So, as scary as it is, I want you to keep your fingers crossed and I want you to have the hope that you've gotten this far. You've made it to this point, and you made it to this point for a reason. And that tells me that you can have a pregnancy that implants in your uterus. That means the plumbing is working. That means sperm is meeting egg. That means something is going right. So have faith in that something being right, and we will keep our fingers crossed for you. So that's also one of the reasons that we check the beta HCG test. We know that 2/3 of those blood tests, the HCG, will double every 48 hours. So We like to see that number doubling. It is not the end all be all. It's just it's another reassuring sign. Once the beta HCG level is above about a 1500, then we know we should be able to see the pregnancy inside the uterus by transvaginal ultrasound. And that's how we can rule out that there is not something like an ectopic or a tubal pregnancy. So again, dancer, fingers crossed there for sure. Marlena, hello, nice to see you. Mohi, thank you for being here. Devo, Sheila or Shelia, I think that says. Um, uh, Loving baby Limkey, I like it. Nurtured Shanna, good to see you here as always, as well as Shada. Thank you as always for being here. Shanna says, I have a positive beta. Wow, the crowd is going wild. The crowd is going wild. Does an estrogen level matter at this point? It was 1308. So I reduced by one pill and now it's only 98. As I said, I don't consider that to be a deal breaker, Shanna. The most important thing for the estrogen is to give you the thickness of your lining at the time of really at the time that you'd start your progesterone, if what you did was a medicated cycle, or if you did a natural cycle, really, the thickness of the lining at the time of ovulation. So, there is theoretically an ideal estradiol level, and it's somewhere between about a 200 and roughly about a 600 is where, if I had to say I wanted to see it someplace, that's where I'd want to see it. Strange that you were doing estrogen twice a day. At twice a day, it was 1308, and then you reduced it to once a day, and now it's 98. That strikes me as strange, and I might be inclined to probably go back up again. That may have been an error in measurement, or something kind of similar there. Congrats to me for my son's graduation. Thank you, Shada. I appreciate that. Here's a question: if someone has a subchorionic hematoma, to what extent should they avoid physical activity, and is pelvic rest still indicated? So that term we use, pelvic rest, I would say, yeah, I would still advise that you kind of take it easy from doing things that might otherwise shake up that uterus. All right. Pelvic rest, you can do the math there. I generally avoid sexual intercourse in that situation, because as long as that hematoma is there, it's likely to want to bleed again. And really it's something that we would prefer to avoid, because it just creates heartache, it creates stress, it makes people, uncomfortable. And so pelvic rest is probably a good idea. I think that the light activity is probably fine. Light to moderate is probably fine if that's what you are accustomed to. But you want to make sure that you keep yourself well hydrated, because dehydration will cause an increase in the hormone that can make you start to have contractions. And that's why on a hot summer day, you may find that you're a little crampier than usual if you're pregnant. Keep yourself very well hydrated to the extent that you can. Hello to Brianna and to Plant Honeys. Thank you for being here. Thoughts on why a transfer doesn't work on someone who has done everything, including laparoscopy to remove endometriosis, has done oral suppression, but still no positive pregnancy test. Asking for a friend who got a chemical pregnancy. Heart is broken for her. She's done everything. What else could she be missing here? Well, so some of that really, I think, has to depend on what they did to get pregnant and on what else may be going on there. So in IVF pregnancies, we know that when you have a euploid embryo, or a tested embryo that we know to be chromosomally normal, there is a 65% probability of being able to get a baby from that. And that's really best case scenario. 65% is not 100%. And so sometimes those things, those pregnancies will not continue for reasons we may not fully understand. Usually has to do something pertaining to the embryo. We think that, well, we know, or at least we believe that the chromosomes we're normal, but we can't really say anything about all those metabolic processes that are taking place in the embryo. And if one of those little things, and there's probably millions of them happening every moment, if one of those little chemical reactions goes awry, then that pregnancy may not continue. In the case of endometriosis, it's a hard one to know, is endometriosis the only first of all, is it even a reason that people don't get pregnant? And the prevailing wisdom is that, yeah, now we think that it probably is real. Um, we can test non-invasively for endometriosis through a test called Receptiva. Um, um, and in most cases, that's really my preference, that we do that non-invasive test, because when we do surgery, I mean, there have been many occasions when I've operated on someone who is known to have a positive receptiva test, meaning to say that the test suggests that they have endometriosis that's affecting the lining of their uterus. We go into a laparoscopy and I can't find endometriosis anywhere. So what's the story there? Where's the endo? Something is causing that BCL6 to be positive on the biopsy, on the receptiva, but you can't find endometriosis anywhere. So what do? You suppress it anyway. And for that reason, I kind of feel like suppression is likely to, in my personal opinion, is a better way to go, because I can look inside someone, and what we always say is that when you look at endometriosis, it is the tip of the iceberg. What you see is just the tip of the iceberg. Um, and by that, I mean there is way more to it than what meets the eye. So I can treat all the visible endometriosis, but there still may be endometriosis there. So if I'm going to use a medication like Lupron or Alyssa to suppress endometriosis, it's going to suppress all that endometriosis. It doesn't matter what I can see or not see, or what I can remove or not remove. So therefore, I feel like, why have surgery for it? Unless you have a pain syndrome, and if you've got very painful periods, pain from endometriosis, then surgery is absolutely makes all the sense in the world. But short of that, so she had endometriosis. The fact that she had that biochemical pregnancy, Shada, tells me that, again, something was working right. She was able to implant that pregnancy. Something was able to grow there. So the system works. There's just some flaw in it someplace. And in most cases, that has to do with the embryo. So almost always when we see a biochemical pregnancy, we are considering that to be an embryo issue. The implantation has occurred, but something's not letting it grow. What else is it? It's probably not the body. It's probably more likely the embryo itself. So yeah, but I understand that kind of heartbreak, because when you um, when you go through that yourself, or when you are an empathetic person, and you see someone else going through the pain of that kind of loss, it's a really difficult position to be in, and you wonder why life throws us these challenges. And I wish I had a good answer for that. I just don't. um, but they're there, and if we can survive them, then I do feel like we come out stronger on the other side. We always can learn something about ourselves, and hopefully take that to be meaningful in the long run. Plant Honey says, what is the best FET protocol post lap and post 3 months of Lupron suppression? Okay, so here we're talking still about endometriosis. And so what you've done there is that you had the laparoscopy and you had the Lupron suppression. So you had really the best of both worlds. Um, in most cases, what the data shows us is that the quicker that you can go into a cycle, um, coming off the suppression, the better off you're going to be. And the data shows us that really for embryo transfer, all we truly need is probably about 8 weeks of suppression. If you did 3 months of suppression, then you really even had more than you probably need, and that's a okay. Most clinics would have you doing a programmed cycle or a medicated cycle FET. Why is that? Well, because when you're coming off of Lupron, if you got a shot of Depo-Lupron, Lupron pulls the plug, it shuts down all of the hormones. And really, what we find is that sometimes it takes a little long. The Depo shot lasts you for about 3 months, but still the effect may linger a little bit longer. And so, if you're trying to do a natural cycle with that, it may end up you may end up stumbling a little bit, that the ovary may not return to its normal function immediately and as predictably as it would if you hadn't had the Lupron. So to be able to continue to control all those variables, to me, just kind of makes sense. There are many programs that will also continue you on a little suppression for some point, that you'll stay on some Lupron, maybe the daily dose Lupron, for a little bit before or maybe overlapping with your estrogen, so that you continue to get some suppressive effect of that endometriosis before you actually have your transfer. So that's kind of the way I would do it. And I've seen that work out really well. So Plant Honeys, we keep our fingers crossed for you, because having to deal with both the laparoscopy and 3 months of Lupron, and now waiting to go to an FET cycle, you have ridden the roller coaster, haven't you? Indeed, you have. Hey, we've got about 7 more minutes. It's about 7 minutes till the top of the hour on Fertility with Fink. I am Dr. Randy Fink from New Life Fertility in Pensacola, Florida, here with you this evening, as we are every Tuesday. If I can't get to your question tonight, please email me at askfertilitywithfink@firstfertility.com, and I promise you we will get to them at the top of the show next week. And my apologies if you sent in an email before for this show, because I was neglectful and didn't get to them before I showed up here. The 5 supplements you suggest for an embryo transfer, do you take those your whole pregnancy, or only until you get a positive HCG? Excellent question there, Angela. The answer is take them until you get that positive HCG, except for the prenatal vitamin. What are the 5 supplements? Prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. Now, as an adjunct there, I would also say fish oil or omega-3 is an important one, but it is very important for egg quality, and it is important with pregnancy itself. As I talked about last week, there's some pretty good evidence that shows us that being on omega-3 or fish oil during a pregnancy improves both the visual acuity and the cerebral scores of the baby. Why is that? Because the retina, the part of the eye that we see from, and the brain matter itself is all made up of phospholipids. Phospholipids are fatty acids, like you're getting in that omega-3. My word of advice on your omega-3, get the odorless or burpless one, because it literally, most cases, comes from the oil of a sardine. They take a sardine and they wring it out and put it into a little capsule. And if you put that in your mouth and you burp it up, it is not a pretty sight. It is not something that you're going to want to experience all the time. So odorless or burpless as far as your fish oil. But prenatal, vitamin D, vitamin E, CoQ10, L-arginine. These 4, you can stop with your positive pregnancy test. The prenatal you stay on, and certainly, as we talked about, your omega-3. Good question. Hey to Nick Betez. After 2 weeks of a medicated cycle, my lining was only at 7. Would you recommend transferring 2 embryos? 7 is enough for a lining. So a 7 millimeter lining at the time of progesterone start is considered to be adequate. I don't know that that would necessarily play into my equation about whether to do 1 embryo or 2. I think, there's lots of factors that go into that. And we talked a little bit about the American Society for Reproductive Medicine and the guidelines as for how many embryos to transfer there. But 7, I would say that's fine. And, if you wanted to stay on estrogen a little longer because it would make you feel a little bit better, your lining will still probably thicken up. There's other things that you can do to help with the lining. Baby aspirin will help with the lining. Some Viagra will help with the lining, and so will intrauterine PRP. But 7 millimeters for an endometrium is enough there, and I think you can feel pretty good about that. Hey to Mallory over on the Facebook side, anything you can tell me about fertility with Hashimoto's thyroiditis? Yes, indeed. So, the thyroid, as we have discussed before, is a little gland that lives right here in your neck. Hashimoto's disease is also known as autoimmune thyroiditis. And what happens there is that your body develops an antibody or an immune response against your own thyroid. And when that happens, it can cause the thyroid to be rapidly turned on with its volume knob high. It can also cause the thyroid gland to be turned down with its volume knob low. It's one of the more common reasons that folks later on in life end up hypothyroid because the thyroid ultimately just tires from responding. But it is an inflammatory condition. It is inciting your immune system. And because of that, we know that there are ripple effects throughout the body as it pertains to fertility and with other organs as well. So we certainly want to keep, in my opinion, I like to keep your TSH level, which is the where your thyroid gland is the function of your thyroid, its volume knob, as it were. We like to keep that at around a 1 if you can, which minimizes the effect and may also just have the effect of lowering your TSH. Sometimes we also look at steroids or other things that we can do to try to minimize that inflammation. Hopefully that helps you there, Mallory, and we're happy to help you at New Life Fertility as well. We're about out of time for tonight, folks. I hope you remember what I say every single week. This fertility business is not the book of your life. It is only a chapter, and what we are here to do is to rewrite that chapter together. So every step forward with love, every step forward with kindness to those around you, and every step forward knowing that tomorrow is a new day full of all new adventures. And I can't wait to see what tomorrow holds for you. So until next week, see you next Tuesday. Dr. Randy Fink from Pensacola, Florida. Good night. See ya.